Hello, everyone. I'm Alex Mauskop. I'm a neurologist with a subspecialty training in pain. And after being trained in pain at the Memorial Sloan Kettering Cancer Center, I narrowed my focus from general pain to headaches, facial pain, and related conditions. My area of research has been the role of magnesium and other non-drug therapies in the treatment of headaches. Some of my colleagues called me Dr. Magnesium since I spent a lot of my career researching and promoting the use of magnesium in neurological conditions, particularly headaches. You can reach me at drmousecop@nyheadache.com. And I also should mention my latest book, which is called The End of Migraines: 150 Ways to Stop Your Pain. You can download it, the book on Amazon, which is a better way to read it than the paper version because it contains hundreds of hyperlinks to original articles. So let's talk about magnesium and headaches in this presentation. Here's an outline of my presentation. First, we'll talk about magnesium deficiency and headaches, the evidence for that, magnesium pathophysiology, symptoms of magnesium deficiency, oral supplementations, and parenteral administration of magnesium. So the first scientific study on the role of magnesium in migraines was published in 1989 by Nabi Ramadan. At the time, he was in Detroit at Ford Hospital. And he found that with his colleagues, Mike Welch was the lead author there, that people who have migraines tend to have low brain magnesium. They determined it by using NMR spectroscopy in patients. And then additional studies confirm that there is an association between migraines and cluster headaches and low free magnesium in the brains of patients with those conditions. That study was published in 2001. And then another researcher published a study showing that it's not just the brain that's deficient in magnesium, but there is systemic deficiency. And this was determined by magnesium load test. That is, you give patient a certain amount of magnesium and then collect their urine for 24 hours. And it turns out that people who have migraines retained a lot more magnesium than people who didn't have migraines, suggesting a whole body deficiency of magnesium. So why would some people be deficient? These are some of the genetic factors that play a role. There are definite forms of hereditary hypomagnesemia, and in the office we see some families, 3 generations of families who are deficient and come for a monthly infusion of magnesium because oral magnesium is not well absorbed. So there are other genetic conditions that you see on the screen here that have been associated with low magnesium levels. So genetics is one factor. And what does magnesium do in the body? As you see, the list of action sites is long, including things that we know for a fact that are involved in pain and headaches, glutamate receptors. Serotonin is prominent. The action of serotonin receptors is affected by magnesium concentration, and the same applies to nitric oxide, and including CGRP, calcitonin gene-related peptide, which, as you all know, is involved in pathophysiology of migraines, and we have a new class of medications that work on CGRP receptors and CGRP ligand. And CGRP connection to magnesium has been known for a long time. This is a 1994 paper showing that magnesium infusion was better than nifedipine as far as treating primary node syndrome in 12 women compared to 12 healthy women. So magnesium significantly decreased circulating CGRP levels, but not those people who were given nifedipine. And not surprisingly, erythrocyte magnesium levels increased significantly after the infusion, but not in controls. So this is a study confirming that there is a connection between CGRP receptors and magnesium. This is our first clinical trial that showed that deficiency is very common in patients with migraines. So our original research started in the early 1990s. The first thing that we did is collected blood samples from 500 patients with various headache syndromes. And it turned out that it was a blinded study in terms of a researcher at SUNY Downstate, where I'm on faculty, Bert Altura, who devoted most of his career to magnesium research. He developed an ion selective electrode, which is a complicated process measuring ionized magnesium, which is the biologically active form of magnesium. So I sent him 500 samples, and it turned out that there was a strong correlation between magnesium deficiency and migraines compared to tension headaches and normal controls. As the next step, we did this study where 40 consecutive patients walked into our headache clinic with an acute migraine were given an infusion of 1 gram of mag sulfate. And 50% responded. Now, its placebo effect in migraines trials is pretty high, especially with intravenous administration. But people who responded, and there were some dramatic responses, tended to have low levels of magnesium, or that is ionized magnesium, and the results came back weeks later. So we didn't know who had low magnesium levels, who had normal, but we found after the infusion that, again, responders tended to have low magnesium. There was a strong, statistically significant correlation between the level and the response to an infusion. We did a similar study in cluster patients. Again, cluster patients, some of them responded very well, and most of those were deficient in magnesium. So what are the other causes of magnesium deficiency besides genetics? Well, stress is a major depleter of magnesium. We know that stress is one of the main triggers of migraines in susceptible individuals. But this probably is the biological connection between stress and magnesium. And you've heard of patients having a heart attack under extreme stress with perfectly normal blood vessels, and we suspect that this is due to depletion of magnesium, which leads to vasoconstrictions and vasospasm. Low dietary intake, processed foods, definitely are low in magnesium, and patients often ask me what kind of foods should I eat. And that's the usual suspects, such as dark leafy vegetables, whole grains, as well as chocolate, which can be a trigger for migraines, but it definitely is rich in magnesium. And then caffeine, and especially alcohol, calcium supplements, all these things have been shown to interfere with the magnesium absorption or increase excretion. We think that hangover headaches, at least in part, are due to magnesium depletion. So if patients ask me, I tell them, if you have a drink, make sure to take some magnesium before going to bed. Calcium supplements interfere with absorption of magnesium, so you may want to take your calcium supplements if you take those separately from your magnesium supplements. And there is a product that has both calcium and magnesium, which is actually good for absorption of calcium. Magnesium facilitates absorption of calcium, but magnesium is not as well absorbed when calcium is present. And then many patients with migraines have comorbidities such as irritable bowel syndrome and other GI disorders, and that clearly will interfere with absorption of magnesium. And chronic illness of any kind has been shown to be also associated with low magnesium levels, people like with diabetes and other chronic conditions. So there have been several studies, small studies, not large double-blind studies, but nevertheless suggestive studies suggestive that in giving magnesium intravenously, as we did in the study, can be helpful. This is a small study, only 15 patients, and 87% responded. Clearly, there was placebo effect involved as well, because according to our study, about 50% of people are deficient, and I think those are much more likely to respond than people who are not deficient. So there were no responses in placebo group in 15 patients, which are also a bit surprising because, again, placebo should have helped some patients at least. But Even though this is not very rigorous study, it's a nice confirmation that in clinical practice, magnesium infusion works. Here's another study by Marcelo Bigal done in Brazil, and they found that people who had migraine with aura tended to respond better than people who had no auras. We find that there is no distinction between those two groups of patients. And as you probably know, many emergency rooms these days give intravenous magnesium as part of the migraine cocktail, along with things like metoclopramide and ketorolac. Now, what about oral supplements? Because clearly intravenous infusion is not practical for most patients. So here's one of the studies that was double-blind, placebo-controlled out of Germany. And they used trimagnesium dicitrate, 600 milligrams versus placebo, 81 patients. And the attack frequency was reduced by 41% in the active group and 16% in the placebo group. And days with migraines were reduced as well. So that was a very positive study. This was a study out of Italy looking not only at menstrual migraines, but also PMS symptoms, or MDQ, menstrual distress questionnaire was the scoring. And again, there was a different salt of magnesium, though, magnesium peroxide. Uh, so that was 360 milligrams of that. And the days with migraines were reduced and PMS symptoms were improved as well. And many women report that taking magnesium supplements helped their PMS symptoms. Here's a study in children using magnesium oxide, yet another form of magnesium, and we'll talk about the role of different preparations of magnesium. And there was a statistically significant downward trend, not quite meeting the primary outcome measures. But again, magnesium oxide might have been not the ideal supplement to try. But it is a safe treatment in children as well as in adults. So magnesium oxide is most widely sold supplement. Unfortunately, it's not the best absorbed. Here's a study of oral bioavailability of various magnesium salts. This first study found that the absorption was equal between magnesium glycinate and magnesium oxide, but oxide caused more stools throughout the day, so it caused loose bowel movements. And the second study showed that the magnesium chloride solution slow release magnesium. It's called slow mag, which is a bit expensive, but well tolerated. And magnesium gluconate, an chelated form of magnesium, were absorbed to the same extent. So these studies suggest that there's not a big difference in absorption, but magnesium oxide is, again, not as well absorbed according to some studies. Here's a negative study of magnesium. This was a multi-center European trial. Olke Pfaffenrath is a German neurologist who led this study. And they concluded that magnesium doesn't help headaches because according to their double-blind study, there was no difference in relief of headaches. Well, unfortunately, they used yet another form of magnesium, and diarrhea was present in 45.7% of people taking magnesium and only 23.5% on placebo. So twice as many patients taking magnesium had diarrhea, which strongly suggests they were not absorbing magnesium. So this study actually does not prove that magnesium doesn't help headaches. It only shows that certain salts of magnesium are not as well absorbed than others. Here's a statement from the American Academy of Neurology giving magnesium level B evidence, saying that it's probably effective, should be considered for patients requiring migraine prophylaxis. But really, it's a problematic statement. I think it should be level A, even though we don't have double-blind placebo-controlled trials. And I don't think it's an appropriate model, because magnesium is likely to be effective only for those people who are deficient and will not do anything for those who are not deficient. So it doesn't make sense to do a double-blind trial putting all patients into these trials. It's just like giving vitamin B12 injections to people with peripheral neuropathy and to see who is going to respond, who is not. the efficacy is not going to be good in people who have no deficiency, and it's going to be better in people who are deficient. So a more logical design of a study would be doing a blood test first, checking magnesium levels, and randomizing those people who are deficient in a double-blind trial. I think those studies would show clearly that magnesium is effective for people who are deficient. It just seems like common sense. Okay, so magnesium testing is a problem. We used serum ionized magnesium levels, which is a very sensitive test, but maintaining the ion selective electrode to measure ionized magnesium is difficult, and it's only available in research settings. The next best test for magnesium is RBC magnesium, because only 2% of your magnesium stores is extracellular. The rest is in the bones or in the cells. So serum magnesium level can be normal, even high normal, and the patient is still deficient. So I would recommend obtaining RBC magnesium, which is available in any laboratory. The chains of Quest Labs and LabCorp, they all offer RBC magnesium levels. Those are much more accurate. But even with those tests, the range is too wide. It's from 4 to 6.4. The patients with migraines and everybody else should be at least at 5 level. It's very similar to with vitamin B12 levels, which is the range is 200 to 1100, but we all know that below 4, 500, you're likely to be deficient. So when you're measuring RBC magnesium, aim for at least 5. With serum levels, if somebody is really at the very top of the range, chances are they're not deficient, but if they're at the bottom of middle of the range, there's a good chance they might be deficient. So RBC magnesium is the way to go. So practical suggestions. And again, some patients you don't have to check magnesium because there is very little downside in telling every migraine patient, try magnesium. I tend to do a blood test first, checking besides RBC magnesium, vitamin B12, thyroid, and all the other tests. But it's perfectly reasonable to recommend for patients to start taking 400 milligrams of a chelated form of magnesium, and glycinate is one of my favorites, and there's aspartate, threonate, gluconate. Threonate has been popular because supposedly it crosses the blood-brain barrier better, but I don't think that science is very strong there. Studies came out only from one lab connected to the manufacturer, and threonate is a bit more expensive. So glycinate, gluconate, aspartate. And if one type is not tolerated, it causes stomach pains or diarrhea, then we switch to a different one. And again, in some patients, citrate or even oxide or chloride can be better tolerated and absorbed. If the patient tolerates, but there's no response, and we do know that patient is deficient, I increase the dose to 400 twice a day or even 3 times a day, breakfast, lunch, and dinner, to see if that provides better absorption. And you can recheck their blood levels, RBC magnesium levels, to see if they're absorbing. In patients who are really deficient and don't respond to oral or don't tolerate oral, we will give a gram of mag sulfate in 10 cc's of normal saline. I do it slow push. Many hospitals and practices don't allow nurses to do IV push, so only a doctor is allowed to push. But in fact, it's very safe. Some people say you need cardiac monitoring. Well, you don't, because magnesium does not cause arrhythmias. If anything, it helps arrhythmias. The standard protocol after open heart surgery is an infusion of magnesium. It has been proven to prevent arrhythmias. So there's no downside. You have to lay the patient down because some people will get orthostatic because of vasodilatation. And we do it slowly because people do feel flushed. And the reason I picked 1 gram of magnesium when I started giving magnesium in the 1990s is because eclampsia, preeclampsia is treated with 5, 6 grams of magnesium, which is safe and effective. So 1 gram is relatively small. Occasionally we go up to 2 grams, and many patients need to have it done just once a month. Some people come a bit more often when they feel that they need magnesium. And there are other additional symptoms of magnesium deficiency that can tell you that the patient is deficient. And those are feeling cold, cold hands and feet, vasoconstriction or Raynaud syndrome. In women, PMS symptoms suggest magnesium deficiency. Muscle cramps in your legs or feet could be potassium, but also often magnesium deficiency. Brain fog, palpitations, all these symptoms can improve with magnesium supplementation. So that's my presentation. And if you have any questions, feel free to email me at drmousecup@nyheadache.com. Check out my book, The End of Migraines, 150 Ways to Stop Your Pain. And we also have a blog at nyheadache.com/blog that I've been running for over 20 years now. Thank you for your attention.